Hello, and welcome to Sepsis Chatter, Common Abstraction Challenges, Part 2. We will be discussing abstraction challenges that have presented themselves over the past couple of months. The information contained in this presentation is based on the Specifications Manual for National Hospital Inpatient Quality Measures, July 1st through December 31st, 2023, and also discharges January 1st through June 30th, 2024. In addition, some of these challenges required that questions be submitted to the QualityNet question and answer tool for clarification. As a reminder, please be sure to refer to the specifications manual that corresponds with the discharge time period that you are reviewing. Let's review the goals. At the conclusion of this presentation, the attendee should gain additional perspective regarding the following topics: determining infection date and time, initial hypotension present, and initial hypotension criteria met prior to arrival. Determining an infection date and time can be a challenge. Guidelines that apply to one scenario may not apply to the next. It's the abstractor's role to recognize which guidelines to apply when choosing the earliest documented infection. We will review the current guidance and go over some examples. Determining the presence and onset of initial hypotension can definitely be a challenge. We will review how to recognize the moving parts, quote unquote, that will affect how you answer this data element. Finally, we will discuss initial hypotension criteria met prior to arrival. We'll review 3 scenarios and apply the correct additional instructions included within the guideline to each one of these. Determining the correct infection time is always the goal, but it's especially critical when it's the last indicator met that determines the onset of severe sepsis or septic shock. Let's look at the guidance. Documentation of infection included in a provider narrative note. If documentation of an infection within a physician, APN, or PA note, nursing note, or pharmacist note does not have a specific date and time, or is documented using the acronym POA, use the date and time that the note was started or opened. If a timestamp reflecting the note opened or started time is unavailable, use the following sources in priority order. First would be the provider-patient care initiated time. That's the time seen, contact time, etc. The second is the scribe time. And third, the earliest time at the beginning of the note reflecting the note was opened or started. What does this mean? Any infection that does not have a time directly attached will be required to have a time assigned. Because a majority of EMRs do not identify a start or open time at the top of the page, we will need to assign a time to a documented infection based upon this guidance. The ED-MD note includes the following. At the top of the note, date of service is 1/1/24 at 1 a.m. The ED time seen is 1:10 a.m. The CT of the abdomen and pelvis shows large free air, likely secondary to perforation of the transverse colon. This has no time attached. Update at 2:30 a.m., peritonitis, colitis, and hypotension. As we move forward with this example, keep in mind that we have 2 documented infections, one with a specified time at 2:30 a.m. and one without, the CT of the abdomen and pelvis and the perforation of the transverse colon. So what's the earliest time of infection in this note? We would assign the ED-MD time seen at 1:10 a.m. to the documented perforation of the transverse colon with no time attached. This is the earliest infection time. The rationale is the date and time of service at 1 a.m. at the top of the page is not considered a note open or started time. So at that point, we would have to refer to the hierarchy in order to come up with the time. In this particular scenario, the ED-MD note includes the following. The top of the note has the date of service 1/1/24 at 1 a.m. J. Smith, a scribe signature for Dr. Jones at 1:25 a.m. The CT of the abdomen and pelvis shows large free air, likely secondary to perforation of the transverse colon. An update at 2:30 a.m. peritonitis, colitis, and hypotension. So what is the earliest time of infection in this note? We would assign the scribe signature time of 1:25 a.m. to the documented perforation of the transverse colon. And the rationale is the date and time of service is not synonymous with note open as previously discussed. Time seen would be priority. However, this document doesn't include this field. The scribe time documentation at 1:25 a.m. is the next priority on the hierarchy list. I would like to switch gears and address determining the presence of initial hypotension. Documentation of the presence of initial hypotension within the specified time frame and prior to the completion of target ordered volume of crystalloid fluids. The specified time frame for assessing initial hypotension is 6 hours before to 6 hours following the severe sepsis presentation date and time, and prior to the completion of the target ordered volume of crystalloid fluids. The guideline defines the criteria met as 2 hypotensive blood pressure readings from measurements taken at different times within the specified time frame. The hypotensive blood pressure readings do not need to be consecutive, but need to be within 3 hours of each other. Determining the presence of initial hypotension. In this example, severe sepsis presentation occurred on 1/1/2023 at 9:14 p.m. The specified time frame to assess for initial hypotension is 6 hours prior to through 6 hours following severe sepsis presentation. In this example, the specified time frame is 1/1/23 at 3:14 p.m. through 1/2/23 at 3:14 a.m. The first blood pressures meeting criteria occurred on 1/1/23 at 11:45 p.m. with a blood pressure of 88/54 and 1/2/23 at 12 a.m. with a blood pressure of 82/50. The initial hypotension date and time is 1/2/23 at 12 a.m. Why is this important? The patient met criteria for severe sepsis only, so the onset of initial hypotension time is a trigger event that will require crystalloid fluid to be administered. Determining an accurate initial hypotension onset time will affect the specified time frame for the fluids to be administered. The specified time frame for the administration of crystalloid fluids is within 6 hours prior to through 3 hours after either initial hypotension or septic shock. If both are present, you would use the earliest trigger event, which in this case is the initial hypotension. So the time frame for crystalloid fluids to be administered based on this initial hypotension time would be 1/1/23 at 6 p.m. through 1/2/23 at 3 a.m. Let's look at another example. In this example, septic shock was documented per MD H&P. Severe sepsis occurred at the same date and time. It was at 1/1/2024 at 8:48 p.m. The specified time frame to assess for initial hypotension is 1/1/24 at 2:48 p.m. through 1/2/24 at 2:48 a.m. The earliest indicators that qualify as initial hypotension are at 1/1/24, a blood pressure of 80/60 at 11 p.m., and 1/2/24, a MAP of 59 at 12:01 a.m. The initial hypotension date and time for this example is 1/2/24 at 12:01 a.m. Nice job. Great, we're done. Not so fast. Don't forget to look at the MAR to review for any crystalloid fluids ordered and administered within the specified time frame. 2,722 cc's were complete at 11:41 p.m. The second hypotensive value that determines the presence and time of initial hypotension occurred after the full target volume was complete. The MAP of 59 did not occur until 12:01 a.m. So for this particular case, initial hypotension would be answered as no. Determining the presence of initial hypotension when criteria is met prior to arrival. The ED arrival time is 4:03 p.m. on 12/1/23. The presentation of severe sepsis was at 4:29 p.m. Two hypotensive values were met per EMS prior to arrival. A blood pressure of 53/41 at 3:35 and a blood pressure of 83/54 at 3:36 p.m. The first blood pressure in the ED was 80/60 at 4:08 p.m. So for patients who meet the initial hypotension criteria prior to arrival, the guideline states, for patients who met criteria for initial hypotension prior to arrival and remain hypotensive when they arrive at the emergency department, use the earliest documented emergency room arrival time. In this particular case, initial hypotension would be the 4:03 p.m. arrival time and not the first blood pressure measured in the emergency room at 4:08. For this example, the ED arrival time was 4:03 p.m. The presentation of severe sepsis was at 4:29 p.m. Two hypotensive values were met per EMS prior to arrival. 3:35 p.m. blood pressure of 53/41 and 3:36 p.m. a blood pressure of 83/54. However, the first blood pressure in the emergency room was 123/70 at 4:10 p.m. The guideline states, to determine the presence of initial hypotension, you may use documentation in pre-hospital records, such as ambulance records, nursing home records, that are considered part of the medical record. You would select value 2, no, if the criteria for determining initial hypotension were met prior to arrival and the first blood pressure reading upon arrival to the emergency room or hospital inpatient unit was not hypotensive. So for this example, there is no initial hypotension met, and we would answer no to that data element, and we would not be searching for any further instances of initial hypotension. In our last example for today, the DED arrival time is 12/1/23 at 4:03 p.m. The presentation of severe sepsis is 4:29 p.m. There was only one hypotensive value that was met per EMS. At 3:36 p.m., there was a blood pressure of 83/54. At 3:38 p.m., there was a blood pressure of 100/65, which is within normal limits. The first three blood pressures that were measured in the ED were as follows: 123/70 at 4:10, 85/65 at 4:25, and 89/57 at 4:40 p.m. So the question is initial hypotension present? And if so, what's the time of onset? Yes, it's present, and it was met at 4:25 p.m. We would use the EMS blood pressure at 336 of 83/54 as the first hypotensive value, and then we would use the hypotensive value at 4:25 of 85/65 as the second hypotensive value that meets the criteria for initial hypotension. This response from QualityNet confirms that we use the hypotensive reading per EMS to determine initial hypotension once the patient is in the emergency room and a second hypotensive value occurs. Takeaways from today's presentation. Determining the earliest infection time included in a provider note requires careful scrutiny. Ask yourself, does the note format include note open, started, or time seen patient contact? Does the facility use scribes? Do all of the documented infections have times directly attached? For those infections that have no specified time, what priority source time should be assigned? On another note, in order to determine the presence and timing of initial hypotension, it's important to recognize which additional instructions included in the guideline apply to the scenario that's being reviewed. Has the full target volume of fluids been administered prior to criteria met? Was initial hypotension criteria met per EMS documentation? Or was one hypotensive value met per EMS and additional hypotensive values were present once in the emergency room? This is a lot of information. There's a lot of guidelines. My suggestion is that you always have the applicable specifications manual open and ready to go whenever you're abstracting cases. Please refer to the following resources for further information. Thank you so much for attending Sepsis Chatter, and happy abstracting!